Welcome to Next Economy Now. The goal of this podcast series is to highlight the leaders who are taking a regenerative, bioregional, equitable, democratic, racially just, and whole systems approach to creating the new economy.
Hi, I'm Kevin Bayuk, a partner and worker owner at Lift Economy. My guest today is Dave Chase. Dave is a visionary healthcare entrepreneur and the founder of Health Rosetta, an organization dedicated to catalyzing a transformation in the U.S. healthcare system through practical and scalable solutions. Health Rosetta is known for helping employers, unions, and communities provide better care while reducing health benefit spending by 20 to 40%. Dave's philosophy is captured in his books, including The CEO's Guide to Restoring the American Dream and his TED Talk, Healthcare Stole the American Dream, and Here's How We Take It Back. I am excited to speak with Dave because his mission to transform American healthcare from a system that steals wages into one that creates community prosperity directly aligns with the Next Economy Now goal of transforming the global economy to serve all life and highlighting what's working. His approach of discovering and open sourcing proven fixes offers a blueprint for rebuilding an entire industry, an industry supply chain that we at Lift Economy believe must transform for a more equitable and regenerative society for a livable future. Dave, welcome to the podcast.
Well, thanks so much for having me on. As I shared when we chatted earlier, I've been listening to the show for a long time. So yeah, totally honored and just feel incredible alignment. It's always fun when you find people that came from a different starting point, but really look at things in quite a similar way.
Yeah, I love that. It's like shared reality. It's like my analysis is similar or the same as your analysis, or you meet people from different perspectives who kind of land in the same place, and that just feels reaffirming. But Dave, can you tell us a little bit about your background or your story? How did you first get into this work, then the work that you're doing today, and just to develop both a successful career and some really inspiring work in this calling to rebuild or transform the healthcare system?
I had a background in health technology. And, that was in management consulting. I started Microsoft's partner health ecosystem. That's, it's like $30 billion ecosystem, 28,000 partners, big, ostensible success. But the reality really hit me when a friend of mine who'd had a similar career path, a successful tech person, I think a good person. And unfortunately, what happened to her happens to way too many people. She got the wrong diagnosis, a wrong cancer diagnosis. That happens at least 1 out of 5 times. This is not unusual. 1 out of 5, not 1 out of 500. And of course, that's going to lead to the wrong care plan. And, long story short, the healthcare system crushed her physically, financially, emotionally, leaving behind a 10-year-old daughter as a single mom. And that was brutal to watch. And I'm one who tries to find some meaning and purpose out of this. And you just go ask why enough, and you get to the root cause of issues and the many dysfunctions that we know about in healthcare. As I unpacked that, it became clear that none of this was an accident. Every bit of the dysfunction was coded literally in legal documents we call health plans. Health plans don't provide any care. They're not a medication, but they govern everything in healthcare. And so when I saw that situation, and then not long after that, there was a day more than any other that stood out. March 9th, 2016. I'd take you back. People are, okay, what was going on then? Well, that was a presidential primary season. And that was the morning that I woke up to the news that Bernie and Trump had won the Michigan primary. And for me, at least, that was this kind of WTF, like, really? Like, I don't follow national politics all that much, but it was the first time I really remember hearing that term populism. And I'm like, okay, what exactly is that? When does it rise? And it rises most frequently when there's an economic depression. It's like, okay, I've heard that term. What exactly does that mean? And there's a few definitions. One of them is 2 or more years of wage stagnation or decline. And I was enough into this unpacking of the situation to realize, oh my God, we are in a nearly 30-year-long economic depression for more than half of the workforce because healthcare's stolen every wage gain that the working and middle class has had. It's not some 10-point conspiracy theory. It is a direct line. And I realized, oh my God, this is way longer than our Great Depression. This is actually way longer than 1930s Germany. We're going to have some crazy stuff happen. It may not make it right, but it makes it understandable. And then I looked also at what this meant for the future. And the largest generation in history is millennials, far bigger than boomers. And today, millennials and Gen Z are about 75% of the workforce. And it's like, oh my God, the most optimistic view on our current trajectory is half of their lifetime earnings are going to go into healthcare. And I don't think that's going to happen. I think that people are going to, I don't want to celebrate what happened last December in New York, but you saw the reaction. It's like, we got to get this fixed. And I fundamentally believe that people are problem solvers the world over, no matter what their resources, and somebody's got to solve this problem. And that's kind of where the Rosetta Stone metaphor came in, where it's like, okay, these legal documents we call health plans, they're like as indecipherable as Egyptian hieroglyphics. Like, who's cracked this code? And I found organizations that had. One I did a TED Talk about. Since I did that TED Talk, that was late 2016. And I think at that time, they had cumulatively saved over $200 million compared to others. And it's now 570 million compared against other. And it was like, we can go into what that was, but like, it was utopia compared to this dystopian reality we had. And so I looked at social movements, revolutions, and realized there's no saving the current system. It's going through a collapse. What's going to replace it? What's in the next economy, the next healthcare economy? And so we're like, okay, we've got to go build that. And that's something where I probably drew the analogy most frequently from the US Green Building Council lead standards. They developed a blueprint, they trained professionals, and then they certified buildings. We're kind of following that same drumbeat. So that was kind of what put me on this quest. And at the time when I wrote the book, the first book that kind of launched this, I could only find 5 successes around the country. And really the question was, can we replicate those successes and make it verifiable that we had replicated that kind of success? And happily, we have thousands of them today. And so that's what, we're working on. And we need tens of thousands, we need hundreds of thousands. But fortunately, we've been able to have success where there's been decades of failure, and it's time to get the word out and let other people know and all of that. So that's a bit of my journey.
Thank you for taking it and for making the choices to put your energy deciphering something that's really inscrutable to most folks. And it's maybe on purpose, but it's just very difficult to get our heads around. And maybe I was going to ask you, what's the best? There's a tension between how much detail to get into and what to say at a superficial level. But I do think for listeners who aren't necessarily familiar with the contours of the health system, and you've probably had this conversation thousands of times. So how do you start to say, like, look, here's the big picture. We have private insurers, we have the Medicare, Medi-Cal, et cetera, and like where the problems start to emerge. But again, we could talk about that for hours. So what's the simple way in to then frame up what you've done to start to decipher and unlock possibilities?
At the highest level, there's perverse incentives. And, I think of the healthcare system as kind of the fire department of our health. And the way our healthcare system has been set up, it would be as though we would reward firefighters for having more fires. And we wouldn't encourage them to do what actual firefighters do, which is inspect buildings and do education and prevention. And so every player in the healthcare system is rewarded for spending to go up and, sadly, really not to improve health outcomes. At the same time, the most amazing people have been called into this healing profession. So it's not that we don't have good people. We have incredible nurses and doctors, and we love them. They're just been put into a system with all the wrong incentives. And, and there's a lot of byproducts of that. And, certainly we talked about the financial outcomes. But again, it's bizarre that if you make a mistake as a health, like a hospital, you're actually making more to fix that mistake. And we have preventable medical mistakes is the third leading cause of death in America. It's the equivalent of more than one jumbo jet going down every day. And there's 10,000 serious preventable medical complications every day. And so once you change those incentives, and we don't have to invent this, there's plenty of places around the world and within the US. And we found the ones in the US because, okay, given the dynamics of our country, like we want to do things that can happen today within the existing environment, maybe against their own short-term financial interests. But that's the biggest thing. And so in a system where you're focused in on well-being, then you invest in things like primary care. It's not a state secret. There's no well-functioning healthcare system in the world not built on primary care. The second book I wrote was called The Opioid Crisis Wake-Up Call. To oversimplify that, if we had not destroyed primary care in this country, we would not have the opioid crisis. It's that dramatic. And so that's a big symptom of the system. And then we have all these players that, again, are rewarded the more we spend, the more their sickness. And so then, okay, that's clearly wrong. How do you, in the current regulatory environment, change that? And we found people who did. And we then came up with the blueprint, just like U.S. Green Building Council came up with this blueprint for how to build buildings and said, okay, we think we can find people who want to run with that. And we did, and we've started initially with these people that, layman would probably call them an insurance agent. They're in the industry, they're called benefit brokers, benefit consultants, benefit advisors. I like benefit advisor. And we said, let's train these people. They're good people. And this first group, directly, they're responsible for about 10,000 employers, about 5 million lives. And so that's really our performance lab. And we said, if we can do this thousands of times over several years, small employers, large employers, public sector, private sector, rural, urban, union, non-union, it would be pretty hard to say we got lucky. And in fact, when you look at the health outcomes of these people, if it could be put into a pill, it would be the blockbuster drug of the century. And any decent person, if they had the cure for cancer, would make that freely available. And so that's where Health Rosetta itself is a public benefit corporation, so it's got a social purpose. We actually initially started as a nonprofit. We found there were things we couldn't do effectively within that environment. And so the nonprofit kind of sat dormant for a while. We actually lit that back up over the last year or two because at the point where we had thousands of successes, great primary care, remove barriers for appropriate prescriptions, get access to world-class medical centers like Mayo Clinic. Like my friend should have gone to the Mayo Clinic for a second opinion, and she would have gotten the right treatment plan. And even when you get the right diagnosis, between 40 and 50% of the time, when you go to a place like Mayo, they change the care plan to the most up-to-date science. And so those are the types of things that are actually pretty straightforward to put in place. And so that's what we've done, is make that straightforward to do and make it easy to pull it off the shelf. What Rosen Hotels, the company I did the TED Talk about, what they did was incredible. Most companies aren't willing to do that level of work. And, if you're a 20-person organization, you don't have the resources. So let's just make that available off the shelf for free. That's what Nautilus Health Institute is about. And what we did is the most boring thing in the world, health insurance contracts, right? We rewrote all of those. That was a 7-figure investment. And that's what we put to the test there's about 400 employers that we work directly in the trenches with day to day. That's our—
How big? Like a small, medium, large?
Pretty small. Most of them, if you add up those 400, it's like probably 35,000 employees. And then there's
Small compared to the Fortune 500, but not like
absolutely.
tiny companies. These are
Yeah.
small
Yeah.
and medium sized enterprises. Yeah.
Yep. Yep. And
Organizations.
by the way, we walk the talk. So when we started offering health plans for our employees, we had 5 employees. Could we do what Walmart could do? No. Could we do most of the things? Heck yeah. And so we proved that out for a few years. Then we make it available to 10,000 employers through the 250 people that we've trained and accredited. And then Nautilus is where we then take the most proven intellectual property of how to do this. Again, this boring stuff like what's the right procurement methodology? How do you codify it in contracts that are fair to all parties and then prove it in data, rinse and repeat? And that's basically the cycle that we found over and over with the most successful organizations are literally spending 50, even 60% less per capita of the best health plans in America. It's kind of unbelievable. But in their case, they've been doing it so long. It's not like their cost dropped one day to 50% less. It's just they stayed flat for a long time. And every year they just look smarter and smarter because everybody else is accepting these jack premiums. And right now, I mean, we're in a time where there's a government shutdown. And it's about healthcare. And the only way you pay less for healthcare is to pay less for healthcare. And the healthcare part's actually cheap. In my county, only 15.6 cents of every dollar actually goes to the clinicians. You know, medical assistance through doctors plus 30% bump for benefits, 15.6 cents. Nationally, it's 23 cents. What's expensive is profiteering, price gouging, administrative bloat, fraud, and some inappropriate care. And we just opt out of that. And you can do that when you rebuild from the ground up. And, you know, and we actually use the framing of this is the next healthcare economy. It is actually already bigger than the US video game industry. It's like a $50 billion industry today. That's big. Now, 5 trillion, of course, is enormous. And we got a long ways to go, but it's not some pie in the sky thing either.
Yeah. So you're talking about $1 trillion bubble. I want to go back a little bit and then forward. Sometimes when I tell people about the perverse incentive and they think about private insurers and they say to me like, but wait a minute, Kevin, it shouldn't make sense. If there's a private insurance company and they collect premiums and then people get ill, make claims, if people make less claims, then they should have the incentive to have a healthy coverage population. They receive less claims, they're going to make more money because they keep collecting premiums. So it should be their incentive to have a healthy population. And I have to kind of disabuse them of how it actually plays out in reality. But can you put some color on that? Because my argument sometimes falls flat and I don't have the right answers. Like, why doesn't it work out? Why doesn't it work out? Like,
well, I mean, it's like, you know, think about a insurance company that insures modes of transportation. Would they rather insure your moped or your moped plus 2 cars, an RV, and a boat? The more they have to insure, and what was codified into law in the Affordable Care Act, to get a little wonky for a second, is something called medical loss ratio. And so what that means is what percentage of the dollars go to care versus overhead or profit. And so it's logical to think that if you cap that at 80 or 85%, which is what the Affordable Care Act did, that would sort of rein in them. In reality, they're either publicly traded organizations or applying the orthodoxy of publicly traded organizations where we as the big carriers tell Wall Street, we're going to increase profits 15% every year. And so if you can make only 15% on every dollar, would you rather have spending be 1 billion or 2 billion? It's, you know, numerator over denominator. They want a big denominator. And also they don't tend to keep the same people year after year. And so even if they had the right incentives, they're like, they're going to be somebody else's problem in 2 or 3 years. Why would I want to invest in long-term things? And so it's very much like the market failure that existed a century ago, where America was getting electrified, the cities were electrified, and the investor-owned utilities like, we can't affordably provide power to these rural places. So 4% of rural America had electricity. That's where cooperatives came in and addressed that. And, you know, to this day, 56% of the landmass is getting powered by rural electric cooperatives. I think it's like 40, 50 million people. And so it's that type of thing where if you know that you're responsible for something for the next decade or century, you think very differently. And we actually think that's the future of healthcare, is sort of the equivalent of that rural electric cooperative, where it's a locally governed health plan utility and cooperatively owned. And using something I followed very closely is the introduction of social cooperatives or multi-stakeholder cooperatives, which is a fifth form of cooperative in the US, where in a healthcare context, this would be owned by the members, the individuals, the citizens, the care providers, and the community. I think that's the right mix. And so that's kind of a little background. I mean, just at the simplest level, they want more to insure. And so that's why they're not incented to keep the cost down.
And you said it's key. It's actually encoded into ACA. So it's like literally there's law that has been developed that reifies the perverse incentive. And then if you marry that with short-term policies and the switching dynamic, you have a mess that has created $1 trillion bubble.
Yeah.
And so let's go. There's always this tension to get wonky, but I want to help people understand. And I'm reciting questions to you when I share about the problem statement and the opportunity space. I get sometimes blank stares and strange questions. And some of it's because it's so, like you said, Rosetta is a perfect branding for this because it's so inscrutable. So you mentioned that some of these people you've trained up. Can you elucidate, like, how do they do this? Is it through a TPA? Because, like, can you just, again, there's like a landscape analysis here, like what's going on? If you're an employer and you have 200 employees and you're going to offer a health benefit to your employees, do you just contract with United Health, or what's typical? And then what's the difference here? Like, how do you navigate the difference? If you could elucidate that a little bit. I know it gets wonky. So if you could,
Yeah, I love acronyms and acrostics. And so my last book was called Relocalizing Health. I'm actually doing a major, almost a complete rewrite of it right now. And there's a acrostic, spells out local. And this is the 5-step plan and how you take it through. The first one is to just a mindset shift. It's leave behind status quo mindset. That is by far the biggest obstacle. Most people think, they're just indoctrinated in the current bizarro world that we're in. And they think that solving healthcare is like trying to solve Middle East peace. And they just think, I'd like that solved, but seems out of control and out of my control and maybe hopeless. And you have to disabuse of that notion. That's where stories and success is the most useful tool. And, we now have, you're a, 500 person municipality, check, we got that. You're a 5,000 person manufacturer, check, we got that. You're a 20 person solar installer, check, we got that. So you want to have somebody like you. But that's the first L in local. The second step is, and by the way, 4 of these 5 steps are invisible to the member or only clearly a positive. Because sometimes people are like, oh my God, this is going to be scary. This is going to be, in the status quo, classic, use fear, uncertainty, and doubt to freeze status quo, or better yet, politicize it, right? Get everybody into their bunkers. And these are very effective techniques. And so we say, hey, just take a step at a time and you get this compounding benefit. The O is optimized plan infrastructure. This is this boring stuff we talked about, all these contracts and all these perverse incentives. One of the case studies I have in my book was a company that's called Copper State out of Arizona. And kind of before they did anything, they just cleaned up these contracts, got rid of junk fees, started watching claims, and they found $1,000 per employee per year of savings. They're a 1,000-person company. Boom, $1 million went to the bottom line kind of before doing anything. But it's this master key that unlocks the other doors. And so the first thing that gets into the care side is the C is carve out PBM. No normal human has ever heard of a PBM. They're a pharmacy benefit manager. These are some of the biggest companies in the world, the most profitable things in the world. The good news, in air quotes, is the shenanigans are so extreme. Like, you can't even imagine how this could be legal, what they're doing to the poor community pharmacist, and on and on. Fortunately, there's a set of good independent PBMs, and you need to carve that out. I mean, we found like 30 different revenue streams these organizations have created for themselves. And it boggles the mind. But fortunately, there are good ethical folks. And it's actually the most recent Nautilus resource. If you go to nautilushealth.org/PBM, and if you're at all into the PBM wonkery, you'll go, wow, we've got an incredibly valuable resource on how to do this right and take control of the procurement process, how to manage it. Again, all this wonky stuff. At the end of the day, what does that mean? The $12 an hour convenience store worker, real story, at one of the employers that owns some convenience stores, she had not had a vacation since she'd been married or had kids because she had a medication that had a $300 a month copay. This is life-saving medication. And of course, she had to keep on it. And one day, everything was free. It was like she got, a $2,500 to $3,600 raise for the first time. She could actually take her kids and her husband on a vacation because guess what? Medications work. Not all of them, and there's plenty of waste there too. But if you actually take the most common medications that are proven, they're super affordable, they're generic, why would you put any cost barriers in front of that? So, if you summarize, the term is plan design. What does the plan look like?
Yeah.
Make good decisions free, make bad decisions expensive. And so that's one of the things. Like we get rid of, there's on formula, like what actually the insurance will pay for are medications that take 2 off-the-shelf medications that cost total of like $20, put them into one pill. And yes, it's kind of nice to take one pill rather than 2 a couple times a day. But do you really want to pay $3,000 for that prescription or $20 for that? And so that's the C. Is there's lots of opportunity there. And typically, it's been going up as a percentage of spending, but typically pharmacy is about 15 to 20% of spend. Sometimes it's up to 30%. And it's a layup to cut that by 30% off and 50%. So that's, then the first thing that they will definitely notice and is different, the A in local is advanced primary care. Right? We need to rebuild primary care.
Yeah.
There should, like the medications, there should be no barriers for that. And that's amazing. People that today, it can take 60 days to get into primary care doc. Some places to find a new doc, it'll take 6 months. Like, is that even primary care? Like, doesn't sound like primary care to me if it takes that long. And so there's this whole movement of direct primary care is one of the key pillars under that umbrella of advanced primary care. And so it's really exciting to see what's happened there. And so that definitely is the first thing they notice, available 7x24. And most of the time you talk to a doc, not just primary care, but definitely primary care, they'll say, I only forced you to come into the office before in this waiting room full of sick people because I
had to file a CPT code. It's the only way for me to get paid or something like that.
Who could blame them? But if you remove that distortion, a lot of times that can just be a text message, hey, this is going on, or I need to, maybe just refill a prescription, whatever it is. Like the average primary care doc is spending 2 hours on insurance bureaucracy for every 1 hour of patient time. And so that's one of the ways you free up that capacity. So that's step 4, advanced primary care. The final step is the biggest payoff, but also the one you want to be very careful about how you do it. And that's leave behind value extracting PPO networks, right? That no opinion in that, right? But the PPO networks should absolutely be in the Marketing Hall of Fame. It is perceived as the greatest value because, again, it's logical. These big insurance companies should be able to negotiate the best deals. Well, if they were incented to, yes, they would. And in other areas like the private side of Medicare, they do want to keep costs down. But let me just give you an extreme example, but this is a real public record example of an inpatient site case in California, TML recovery versus Cigna. You can go look it up. The claim that came across was $996,000. Well, let's put aside whether those were all legitimate charges. Typically about half of them aren't, sometimes more. But let's just assume those are legit. Cigna said, oh, and this was a self-insured employer, by the way. And so they said, oh, no. Actually, they billed $11 million. And you're like, why would they do that? Well, they had this contract in their PPO network, this shared savings program, that if they let the bank get robbed and then they recover some of that robbery that they happen to have perpetrated themselves, they'll get a 30% finder's fee or something like that. It tends to vary a little bit. So in that case, they quote unquote saved $7 million. So the employer paid $4 million for this $996,000 claim. Cigna made $2.5 million. Their partner MultiPlan made like $670,000 for doing some of the sleight of hand, and the provider got $875,000. These are the types of things that are codified into these agreements that most employers treat them like I treat, terms of service on some consumer website. Check, I agree, right? Who's going to read that stuff? Well, that's how 30 years of wage gains get stolen, is not reading those contracts. And we have this thing we call plan grader, where we score a health plan. And we found through that 95% of employers never even look at those contracts. They certainly don't negotiate them. And they've basically just given the healthcare industry an unlimited corporate credit card to like have the best parties ever at the Ritz and, order the Dom Perignon, and they do. So that's all very fixable stuff. And so we work with independent TPA, we work with independent PBMs, we work with aligned healthcare providers, and we have contracts with, typically it's a different type of contract, sometimes literally a direct contract. Sometimes there's just better aggregators of contracts, and we kind of mesh that together. And brick by brick, you've rebuilt the health plan for the major things that matter there. And yeah, you can go deeper and wonkier into some of the things, but those are the big things you do, is just work with good, ethical organizations that have aligned incentives and make sure it's working, and you're off to the races.
I think what you said still makes it, for some listeners, maybe for myself included, it's gone from complex and like peace in the Middle East, I just don't even know how to start, to like, actually, it is still complicated. There are bricks, there are these elements that are out there, and it's a bit bespoke. And in this state, it might be a little bit different than that state. And these players are here and those players are there, but the bricks exist. And so if you have the research that your organizations have done, and like, you could go grab these bricks and you could, with trained professionals, piece it together. And then let's talk about the results. That you have some outstanding case studies on the Health Rosetta website. So, and you mentioned some already, but maybe share some just for people who are like, what does this mean in practice for different organizations or communities, school districts, unions, some of the groups you've worked for? Share some of like what this liberation means. Like once they piece those bricks together, like I think listeners would be, surprised. I was astounded. It's impressive.
Yeah. I mean, I mentioned Rosen. They've been doing it over 30 years. And when we actually scored their plan, even though they were best in class, we're tough graders. It was like a 70. And now most status quo plans are a 5 to 17 out of 100, but they did this great thing with primary care. And what that enabled was amazing. Obviously, this cost savings, great for the business, but for the member, they had this advanced primary care, no barriers. And this is a very challenging workforce in terms of disease burden. Just to give you one data point that's normally a budget buster, 65% of their pregnancies are categorized high risk. They had a bad experience early on and realized, they had handled the primary care and specialty care. They relied on partners. They realized the partners in Florida are kind of a train wreck. And so they took that in-house. And so they had direct contracts. They worked with different PBMs, different TPAs, all that kind of blocking and tackling. And then the employees got free advanced primary care on the clock. And if you didn't have transportation, they would take you to the clinic, because initially those had been barriers like, oh, we've got free primary care. Why is nobody going there? Well, these are maids, they're maintenance workers that take food off their plate if they're going to the doctors. Okay, well, they're on the clock. Some people still go. Why aren't they going? Well, they don't have transportation. The clinic's a mile away. They're different property. Remove that barrier. Again, just problem solvers. And the amazing thing about that is they save so much money. They took a fraction of that savings And this actually became the inspiration for what we define our purpose as. We call it the Health Rosetta dividend. We know that we waste more in the US healthcare system, 30 to 50% of all dollars, than the entire Russian economy. It's grotesque given the needs that are out there.
Mm-hmm.
And then what they did is they said, we're going to subsidize healthy food. But the amazing thing was they fully fund, after you've been there for a few years of service, they fully fund college education for the employees and their kids. Like this is $250,000 a pop. You can imagine what this does for retention in a high turnover industry. It's like 1/6 of the level of turnover, but they didn't stop there. They adopted a once crime-ridden neighborhood and said, we're going to fully fund daycare, parent education, preschool or pre-K, after-school programs, and now hundreds of college scholarships fully funded. So 2/3 of US college graduates are graduating with debt. They graduate with zero. So they're really enabling the American dream, generational wealth building. And they've been doing it so long. There's now kids of the initial students who graduated. It's really cool to see that. So that's Rosen. That's one example. Pacific Steel and Recycling. So that's a kind of medium big. They grew from 500 employees to 5,000 over this time. Not enormous employer, but significant. Let's take like a little bit smaller one. Pacific Steel and Recycling. 10 years ago, they're spending $8 million on their health plan. And by now, they would be expected to be spending at least $12 million. Now, for the last 4 or 5 years, they've been spending $3.5 to $4 million through direct contracting, through great PBM, the stuff we were just talking about. They happen to be a employee stock owned company. And so I asked the CFO of that organization, what would you have had to do to have the same bottom line impact as what happened with your health plan? This is a 130-year-old, slow growth, low margin company. He said, we would have had to increase top line sales revenue 25 to 30%. That's pretty tough. For an employee owned company, their nest egg dramatically. I mean, they're now forklift drivers making $45,000, retiring. They've been there a while. It's not all their health plan, but basically their nest egg doubled into 7 figures because of the health plan. And then a more recent one is that's actually the first example we call community-owned health plans. So think of it as like a cooperative, like we talked about earlier, that we're building towards in Ohio. This is the 8th poorest county in the state. Frankly, they've been on a losing streak for probably 30 years now because of manufacturing moving offshore. Why did it move offshore? Healthcare costs was a big driver of that because there was this premium on, like you may have heard the stories about every GM car back then had a $2,000 premium because of healthcare costs. So rather than solving the problem, they just, moved jobs out of the Midwest. And so the first real driver of word of mouth, it started with some private sector employers. I think there's an auto dealer, a chemical company. Literally the first employer in that community had 38 employees, right? This is not exactly Walmart. And they did this. The benefit advisor, a guy named Bryce Heinbaugh, he was going to leave the industry. He's a good guy. He hated doing what most brokers are doing this time of year where, pardon the expression, but I call it turd polish season, where they're out there getting great news, guys. You're going to pay more and get less, but it's good. It could have been worse. And
because this is open enrollment season. This is the time.
Yeah.
Okay.
This is 80% of plans renew on January 1, and so there's a lot of pain being delivered right now out there. Instead of in our world, it's a different story. And so the real game changer was the CFO of the school district, small school district, only like 300 staff, said, we're just getting hammered by this healthcare thing. And it's really tough for us to hire teachers because it's just eating up their paycheck and they haven't really gotten a raise in years and years. Can you help? And they put in this plan July of 2020, kind of a unique time to put in a new plan. And by the time the school levy was voted on in May of 2021, and even in this challenged community, they usually pass these school levies, but it failed. Normally, that would have been a disaster. Cut teachers, cut extracurriculars, cut transportation. Even in that short amount of time, they'd save more money than the entire school levy. This was like $2.4 million in that first year. And they were basically, their reserves had gotten down to a few 100,000. I mean, this was like, you as a public entity, you had way bigger reserves. And 3 years later, they had like a $7 million surplus. They're like, geez, what should we do with all this money? So those are the types of things. Again, great primary care, independent PBMs, independent TPAs, centers of excellence, direct contracts, basic blocking and tackling. They didn't do all of it at once, but took it a step at a time. And that's the other thing is you don't have to rip off the Band-Aid and do it all at once. If you do that, that's fine. We can support that. But most of the time, it's do it a step at a time.
And what makes that last example prefigurative of or sowing the seeds of that community vision? Can you share a little bit more there? Yeah.
Yeah, exactly. I mean, if you fast forward to, okay, we have this dystopian reality. What is this next thing that's going to replace that? And, I just gave the name community owned health plan to something that I saw in places like Jönköping, Sweden, or what the folks in Mondragon are doing, or what the Alaska Native peoples are doing in South Central Alaska. Another incredible story. And they just took over ownership of it and governed it themselves. And so the theory of change is each of those employers in Ashtabula, Ohio, that's the community, they're all operating independent of each other, but all on the same chassis. Coming out of tech, I'm like, I remember a time where, people had PCs that weren't connected and they're like, geez, we should share a printer or share files. So you had local area networks. And then like, gee, we should talk to our other offices or our trading partners. So you had wide area networks. They were all on TCP/IP. And then boom, the World Wide Web came along and then they're on that same thing. So it's the same type of thing where once you have that, then at a certain point, there's things called captives. They're essentially a cooperative insurance model. That's one way where you're like, okay, let's share this level of risk. Because at that point, all these companies are just tiny insurance companies, but they don't want to be in the health insurance.
And it's because they have their like self-insured group plans, and they each have their own. But if they collaborate in the sense,
and so they're doing that at the micro level. But then you go that together and you say, okay, let's put these all together. We're all sharing this, and our members, our business, our doctors, our nurses can all be a part of this that we will collectively govern. That's what happens with the NUCA model, which is this care model in South Central Alaska. And then, hey, you're a freelancer. Would you like to jump on this? Yes. Do we need to check some additional boxes to be available on the ACA exchange? And are there some things to do there? Yes. But we already are running and have managed the risk for many years and have the contracts for all the elements. And then again, there's some different boxes to check. If you wanted to, I don't know if we want to go down this rabbit hole, but like in Medicare, which gets a lot of attention, there's a private version of Medicare that John Oliver just did a brutal takedown on called Medicare Advantage. And it's problematic, but it's not legally required to be problematic. It's problematic because of Wall Street incentives. And on the negative side, it's easy to game that game, so to speak, and take advantage of it. On the positive side, standard Medicare only pays for medical things. When we know 80 to 90% of health outcomes are things like healthy food, good neighborhood, safe neighborhood, clean air, clean water, and the Medicare, the thing that allows it to get abused by Wall Street driven organizations, imagine instead it was actually owned by the community. And if you look at what a NUCA, or there's a few of these good Medicare Advantage plans. My parents have been in one, and I saw it through my dad's 5-year Parkinson's journey, where it's actually can be beautiful. And they're like, gosh, like in Jönköping, Sweden, which is one of the templates we follow, they're like, hey, these seniors are showing up at the hospital. Yes, their medical diagnosis is, congestive heart failure, COPD, but their real primary diagnosis is they're lonely. They're depressed. They're living in a food desert. And so if you have those dollars governed at that community level, we're like, hey, let's have some senior programming or intergenerational stuff, or, again, it's not rocket science stuff. And so we believe that, that's not on our immediate, sort of punch list. But at that the best Medicare Advantage plans, I mean, the one my parents have been in before it was ruined by Amazon because they acquired it, it was the best of the US healthcare system. It
Yeah,
was, and
yeah,
it probably saved the taxpayers $250,000 through my dad's 5-year Parkinson's journey. It was way
yeah.
better for him, way better for my mom, way better for me and my siblings. And in the right hands, it could be great. In the wrong hands, it's just a big kind of legalized fraud scheme.
Yeah, there's so much there. So, in community governance, either in existing structures that have had to navigate box checking, which is complicated, not complex, but Rosetta can help. It's maybe not your priority, but you can get there. There
Yeah.
could be a kind of a syndicate of community governance, and then all of a sudden, things like social and environmental determinants of health, which we know all the data out there on like actual well-being, or at least in like non-communicable diseases, diet, activity, loneliness, community. Those are the frontline,
Yeah.
treatments that if we dedicated resourcing to those areas, it has the potential to dramatically reduce the actual total cost of wellness. And so community leveraging even existing structures, Medicare Advantages plans could structure dollars to resource those types of outcomes that could actually contribute to community health. And part of that is through this idea of sharing, cooperating in a region, a bioregion, or a group of entities kind of sharing and developing a community plan like the NUCA system and some of the others that you've mentioned have
Yeah.
done. So the prefigured seeds are out there. They exist. The
Yeah.
seeds are out there. And Rosetta has kind of been studying them, documenting what's working, developing open source and information that could be shared to eventually navigate there. And in the meantime, we've got trillions of dollars to address that's in the broken system. So
Yeah.
before these bioregional, community, cooperative, fully integrated health systems addressing the social and environmental determinants of health, those will emerge. But we've got a lot of fat to trim at the moment in terms
Yeah.
of like,
Well, and
yeah, yeah,
that bioregional
yeah.
piece is really critical. And we find there's kind of this Goldilocks zone of, 25 to 500,000-ish people,
Uh-huh.
big enough, but not too big. And
Yeah.
then if it's governed at that scale, like we were just talking about, you recapture that waste and then turn it into well-being, right? It's,
Right.
I joke, it's like waste into fertilizer for restoring the American dream. Like
Yeah.
you actually
Yeah.
have the money to do the things we want to do in food and climate and these other things that, regenerative economies. And we had people not only fund college educations and daycare and food, but, home solar, like there's an incredible sum of money that's
Yeah.
sitting there. And
Yeah.
the way I describe it to people is every community has a river of healthcare money flowing through it. The source of that river is the community itself. It
Yeah.
should work like a water cycle, but instead there's these giant corporate pipelines that divert it. And like in my county, about 250,000, at least $1 billion, probably $2 billion of the $3.4 billion we spend across all ages is extracted out of our local economy for fundamentally local service. And I call it economic development 3.0. Like we actually have the money. We're just
Yeah.
squandering it and we need to redirect it. And it's actually in our control. We can do that today if we want.
We can, and it's tricky. And that's why the team and the years of figuring out the complicated health plans and the landscape is really courageous work. I'm really grateful to you, Dave, and Health Rosetta for all that work. I imagine there's people listening to this and saying, hey, maybe they're an employer or founder or a management team or whatever, and they have a couple hundred employees and they're just maybe with one of the big providers and they've never graded their health. They've never looked at their health plan with a close scrutiny. So curious if you could respond to the listeners who might be in that position, or maybe there's an employee listening who's like wants to get their employer's attention and say, hey, you got to talk to these folks. And then maybe more big picture, like what's next for Health Rosetta? I'm curious if you could respond to both those. Yeah.
Yeah, you kind of alluded. I mean, just get a handle on it. And I can help people who have less than 5 employees. And there's some things, and we were there. So but really, once you have 5, you have some real choices. Obviously, you get bigger, you have even more options. And so, it really, you have to know where you are to know where you're going to go. And so that's where the plan grader is that. And it will take we have a plan snapshot. It's like 14 questions will take you 15 minutes off the top of your head. If you have 45 minutes, then you can get that full report. And we have people, you go to healthrosetta.org/map. You can find somebody in your area who can take you through that. But, your folks, just email me, dave@healthrosetta.org, and I'll help you out and get you started. So that's really, it gives you this roadmap. Coincidentally, I have a podcast called Relocalizing Health, and I was doing an interview this morning with a company called Pfeiffer, Pfir, out of Alabama. And they were pretty on top of it relative to others when they got started a little less than a decade ago. They had a 37 plan grade. They're at 74 now. And they're now funding scholarships. They're funding summer enrichment programs. They've made primary care available to their retirees who they've got no obligation to do. And, these types of things. So they're just marching down that path. So those are the types of things. Just start there. And you'll get a punch list in this report that you can start with. And obviously working with the right person, they can take you down that path. And it's quite straightforward. And we have, you go to healthrosetta.org, you can download any of my books for free, and it will send you an email series that, you just want to learn a week at a time, kind of go through little executive summaries of those chapters. It's a good way to get educated. And that's really where most people are starting. And then, on the horizon, in terms of what's next, it's really been, at some level, a maturation of these community health plans. We have, I think, about 7 that are really pretty far along. There's another handful that are building that foundation. And we get together every year at an event called Rosetta Fest that, will be in Nashville this next year. And so certainly people can go to that. We have all these videos available from it. But probably the biggest thing has been this Nautilus, where we've now finally had these things so proven that we're making them available for free. And, if you're willing to get into the wonkery a little bit, and that's probably the people you're working with that will actually use those, but they don't have an excuse. There are freely available resources that are from the most proven people in the industry. And frankly, going back, if you're not working with the right benefit advisor, these insurance agent, benefit brokers, whatever you want to call them, it's pretty hard to get from here to there. And so that's where we encourage people to get a second opinion on that. And unfortunately, they're good people, but they have the wrong incentives for the most part. And we, these are great professionals when they're doing their job right and have the right incentives. They should be well compensated if they're doing the right thing. But unfortunately, they're really owned by the carriers. And, the carriers can yank away 40% of their revenue overnight if they don't follow what they want to do. And so you got to get out of that mess and work with the right people. And that's why we train those people and equip them to do the right thing.
Amazing. I'm just thinking about questions people might ask me. So I've had people say to me, but Kevin, maybe they're big fans of Sanders or whatever. There's a Medicare for all. Isn't that what we should all put our time on? Like, isn't that going to be the thing that answers everything? And, I have to go through a nuanced response, but I'm curious if you could just share, if somebody said to you, Dave, like, God, Dave, all this hijinks and gymnastics you're having to go through to like figure this out. Isn't there a simple cut through? Can't we just make Medicare for all, which obviously has been fraught. So that's easy to say the words, but let's assume that it were true and you could make Medicare for all. Why is that? Is it enough or why is it not enough?
Well, it's having low expectations, right? Because we have three we have 3 failures in our system. There is administrative bloat, there's pricing failure, there's no correlation between what you pay and what you get, and there's overtreatment. And so if you go into the different boxes of healthcare, one or the other is better. Like Medicare is better on pricing failure, but they're awful on overtreatment. There was a piece in the Saturday Evening Post written by a doctor, How Doctors Die. And they're like, we do stuff to people end of life that we wouldn't do to a terrorist. And you talk to anybody, any provider that's dealing with Medicare, there's incredible administrative burden, even if it's not at the, there's sort of this misnomer that there's no administrative burden there. And guess what? Who's administering those plans? It's all those big carriers. And so we can do way better. We have the opportunity to leapfrog. And as we talked about, we're spending 90% of our health related dollars on what drives only 10 to 20% of health outcomes. So it's a mistake to only fund medical stuff. And yes, it's better than being uninsured. And yes, a lot of employee plans suck. So when they go on to Medicare, it's better, but we can do way better. Medicare doesn't cover vision. It doesn't cover hearing. It doesn't cover all these social determinants. And so we can do so much better. And that's where the system's going through collapse. If you pay attention, you could argue it's already collapsed in rural settings and critical, underserved, challenged communities. And there's a lot of very sober people that are deeply experienced in the industry that believe the system's going into collapse. And it's like, let's replace it with something far better. And so that's what I would say is if it was awesome and overperforming relative to the rest of the world, it's like, yeah, let's go into it. Let's make it a hell of a lot better. It's not that great. We just have such low expectations in the US healthcare system. People think that that's going to solve the problem when in fact it's not that great.
Yeah. Thank you, Dave. That's very helpful. Maybe just one more question. Again, I don't want to overstay my welcome here with your time, but let's take it out a little bit, like a generation out, maybe 2 generations out. If we start to get things right and build off what Health Rosetta has got the ball rolling here, and you see the trends of what's happening and the positive trends of how we could get to a bioregional kind of cooperative community health system. It's just a fanciful, fun question. What does it look like? What do you see in a next economy, a next health system where it's actually working? We might have touched on some of the pieces, but I'd just love to hear your take on it.
From just a healthcare standpoint, there's no barriers to access world-class healthcare that's available in your community. And if you need to go out for a complex thing, it's available. We already are spending more than enough money to not only fund a world-class healthcare system, but to restore funding to what's actually driving 80 to 90% of health outcomes. And so then we can do the things that are so impactful in terms of better food, fully funding daycare and after school programs and college educations, and allow people to fully flourish. And you think about the communities that we love to visit. It's those things, that great food, it's the great art, it's the great culture. And that's actually part of what I see as how we drive this change is in those communities, have the community paint that vision, whether it's spoken word, murals, music, that this is the future worth fighting for. And actually in my rewrite of my book, that's how I finished the book, is like, I blatantly ripped off Rob Hopkins, that where he did this time travel from, I think he called 2030. I'm going 2035 because it takes a little longer in healthcare. Like, I came back. This is an incredible world. And if any of your listeners want to read a draft of that, I'll send it to you and you can see whether this is the kind of future you want. But everybody can reach their full potential and they're not impaired by cost of healthcare, cost of education, cost of food. Like, we can easily afford it when we don't squander the money. And that's something that everybody should have access to. And it's very doable. And I think a community that if like they really rallied and damn the torpedoes, they could do it in 5 years. No joke, right? If they really, we have a pathway, whether you're coming from Medicare, employer, individual, we have a pathway to get there if we just hunker down and do it. And certainly if there's some help from the state or federal level, maybe that goes faster, but we actually don't have to do it. We can get going today.
Amazing. Well, I really appreciate you, Dave, for spending time with Next Economy Now. I also just really appreciate what I know takes a bit of fortitude and tolerance to wade through the administrivia and all the paper tigers, all the things that are really reifying the business as usual, exploitative status quo. And it's right there. It's encoded in these arcane documents and systems. And it just takes quite a bit of just like stamina to like get through it. And you've obviously lived it, and at any point in time, you could have avoided that and done something else, but you stuck with it. And heroic comes to mind. It's a great service. I really appreciate you for doing that work and all your team at Health Rosetta. Thanks again for being on Next Economy Now. And I look forward to continuing the conversation. I'm sure we have much more to talk about down the road. But
I'd love to. I really appreciate the opportunity. And it's the individual human stories every day that keep the fuel going it is a long, tough battle. There's no question about it.
Well, thanks, Dave. Really appreciate you.
Absolutely. Thank you.
Hey, Next Economy Now listeners. If you enjoyed this conversation and are looking to dive even deeper into the B Corp movement, you'll love our new podcast, Beyond the B, hosted by Lyft Economy's Amy Allison and me, Ryan Honeyman. Beyond the B is your insider's guide to the B Corp movement. You'll learn about the new B Corp standards shaping our community, how the B Corp movement is navigating the various tensions and challenges of growth, and how businesses like Patagonia are putting their commitments to people and planet in practice. Check out our latest episodes and free resources at lifteconomy.com/beyond. You can also subscribe to Beyond the B on Apple Podcasts, Spotify, YouTube, or wherever you get your podcasts. Thanks again for listening.
Thanks for tuning in to today's episode. Before you go, we wanted to let you know that our spring cohort of the Next Economy MBA begins on March 24th. If you're an entrepreneur seeking to create a business that works for all life, a member of a team looking to transition your organization into one that is more regenerative and democratic, or someone who's considering a career or livelihood transition in alignment with your values, we designed this course for you. Over this 9-month learning journey, you'll have the chance to learn practical skills around business and life design based on our work with over 500 social enterprises. In addition to live sessions, you can deepen your experience and practice with special sessions, affinity groups, and connections with over 700 alumni who have participated in the course. Interested in learning more? Visit lifteconomy.com/MBA to view our course curriculum and sign up for a free intro with one of our facilitators. If you're ready to sign up, you can use the code PODCASTMBA to save 10% on tuition. We hope you'll join us.